Welcome to the Currents of Public Health webinar series presented by the School of Public Health at Georgia State University. My name is Brian Greer and I'm the Director of Development for the School of Public Health. The goal of this series is to explore relevant public health topics with members of our community. Today's topic is the effects of COVID-19 on people with intellectual and developmental disabilities. Our guest is Dr. Erin Vinoski Thomas, who is a research assistant professor at the School of Public Health at Georgia State. Dr. Vinoski Thomas works primarily within the Center for Leadership and Disability, whose mission includes translating research into sustainable community practices that lead to independent, inclusive, and productive lives for people with disabilities. Dr. Vinoski Thomas's research focuses on disability health disparities, an emphasis in identifying and promoting holistic health behaviors, particularly among women and girls with disabilities. Prior to earning her PhD, Dr. Vinoski Thomas served as a Disability and Health Fellow with the National Association of County and City Health Officials. In this role, she supported a national program providing technical assistance to local health departments across the U.S. to increase their inclusion of people with disabilities in their policies, programs, and services. Today's work will be guided by three general questions. What are you doing? Why is it important? And how can we get involved? A quick note, if you have a question at any point during our conversation, please feel free to type it into the Q&A box and we will try our best to answer. So let's begin. Dr. Vinoski Thomas, welcome to the webinar. Please tell us about your research and what you're doing.
Great. Thank you, Brian, and hello, everyone. Thanks so much for having me here. I'm really looking forward to discussing some of the work that we've been doing at the Center for Leadership and Disability throughout the pandemic. So I'm going to start by talking in detail about one specific research study related to COVID-19 and individuals with intellectual and developmental disabilities. And then a bit later on, I'll mention some of our center's other initiatives around working to enhance health and safety for people with disabilities in Georgia, both during and of course, as we emerge from the pandemic. So the first question, what are we doing? We're doing a research study. So this study began in May 2020, and we just recently wrapped it up in February of 2021. And the overall goal of this study, which was funded by a grant from the Natural Hazard Center at the University of Colorado at Boulder, and then another grant from the Georgia Council on Developmental Disabilities, was to explore the effects of COVID-19 on quality of life among people with intellectual and developmental disabilities, or IDD, and the care workers who support them, who we refer to as direct support professionals, or DSPs. So to achieve that study goal, our study used what's called an explanatory sequential mixed method design that had three major components. I know that's a mouthful, so let me explain that a little bit. The study was explanatory because the later studies were conducted to help explain the findings from the study or the studies that preceded them. The study was sequential because the various components were conducted, one after another rather than, for example, being conducted all at the same time. And the study was mixed method because it used both quantitative and qualitative approaches to achieve its intended outcome. So in study one, we conducted an online survey of individuals with IDD and DSPs. And then we followed that survey with study two, which was a series of virtual interviews conducted at 2 time points with individuals with IDD and DSPs. We followed that study with, you guessed it, study three, which consisted of more virtual interviews, this time with disability and health policy experts in Georgia and in neighboring states. So I'll talk in detail about each of those phases. Starting with study one. So to assess changes in quality of life, again, among people with IDD and DSPs that had occurred from before the pandemic into about the first 2 or 3 months of the pandemic, we used what's called a retrospective pretest survey, and we administered that survey online. So the retrospective pretest approach is really just like administering a traditional pre-post test, which is really a very common method in research. But with a retrospective pretest, you do the pre and the post tests at the same time. So I'll explain a little bit further because I know it sounds like you can't do a pre and a post test at the same time, but you can, and we did. So with a traditional pre and post test, you administer a questionnaire, And then there's some event or intervention that happens, and then you administer the same questionnaire after that event or intervention. And you compare the findings from before and after, or pre and post, to assess whether some change occurred. So with a retrospective pretest, you administer the pre and the post test, but again, you give both versions of the questionnaire at the same time after that event or intervention. So this approach is really useful in disaster response research when, there's no impetus to pretest someone or some group of people about an event that we obviously didn't know was going to occur. And so the questionnaire that we used in this study is called the Quality of Life Questionnaire. And it measures 4 domains or 4 areas of quality of life. And those areas include personal life satisfaction, work competence and productivity, empowerment and independent living, and belonging and community integration. So this initial survey reached 61 people with IDD and 76 DSPs. And, without getting too deep into methods and findings, I can just summarize by sharing that the survey, or the numbers, told us basically exactly what we would expect to find, that both people with IDD and DSPs reported steep and statistically significant declines in all 4 areas of quality of life that we measured. You can see that the most significant declines were observed in the areas of work competence and productivity, and belonging and community integration for the people with IDD who participated in the survey, and then in the areas of personal life satisfaction and belonging and community integration for the DSPs who participated in the survey. So again, in summary of study 1, the survey showed us just a real quick snapshot of what was going on in these populations during this period of time. So then we followed the survey with interviews to help us really explain the why. So we're on to study 2 now. In study 2, we virtually interviewed 8 people with IDD and 10 DSPs. And we analyzed those interview data using a thematic qualitative analysis approach to identify themes in the data that we saw across all of the interviews. So the people with IDD that we interviewed described, really above anything else, experiencing isolation. And they described trying to figure out how to deal with, these major effects of disruptions in their routines, like not going to work, not going to school, and dealing with disruptions in relationships with the people that support them, including, their DSPs, and also including their family members. And the last major theme for DSPs was that they, or for people with IDD, excuse me, they talked about this sense of fear and feelings of uncertainty about the COVID situation and about the future. One young man that we spoke to really just said, I just want someone to tell me when this is going to be over so I can go back to work. And I think we all kind of embraced that feeling, at least at some point throughout the pandemic. The DSPs that we interviewed, of course, shared these similar concerns, but there were some additional layers to what they shared. So on top of those concerns about isolation and disrupted routines, they reported experiencing overwhelming burnout. They described being under sort of like this constant pressure all the time to keep themselves safe so that they could keep the people that they support safe. So they really talked about this as sort of bringing COVID to work. And transmitting the virus to the people that they support and care about. And another really important theme that came up for DSPs in particular, who identified as Black and as Asian American, was the extreme emotional distress associated with living and working as a DSP during COVID, given the ways that COVID, has been and continues to be racialized, in the ways that it has disproportionately affected communities of color, and the occurrence of COVID during a period of heightened racial violence and near constant media coverage of racial violence across the country. So these themes, again, these were shared during interviews, and they really do help explain those statistically significant decreases in quality of life that we saw in study 1. And I might be a bit biased here as a mixed method researcher, but I do think that these findings demonstrate the real strength of mixed method approaches in illuminating both the what, or the what's happening within these populations during this time, and the why behind it. So after we completed studies 1 and 2, we moved on to study 3. At this point, we had a sense of what was going on, why some of it's happening. And so we conducted a small, what I'll call a knowledge translation study to understand the best ways to take that information and package and communicate our findings from the surveys and the interviews and translate that knowledge into information that supports real policy change. So to do this, we drew from a known or a published knowledge translation framework from Lavis and colleagues to develop and to refine the questions that we wanted to answer during this phase. And so the Lavis framework identifies the 5 pillars of knowledge translation as what, to whom, by whom, how, and to what effect. And so we took those 5 pillars and adapted them to really to fit our specific study context. And so the questions we asked through this study were, which study findings should be prioritized for knowledge translation? How should study findings be translated to increase their uptake by policymakers? And which stakeholders need to be involved in this knowledge translation process and how? So to answer the questions, again, I mentioned we did more interviews. This time we interviewed individuals with disability and health policy backgrounds who represented organizations like state disability, developmental disability councils, state protection and advocacy organizations, other centers like ours that are designated as University Centers for Excellence in Developmental Disabilities, and then state-based care worker organizations. And so through those interviews, we identified 4 policy priorities, and those included increasing access to state, home, and community-based services waivers that allow people with IDD to receive support at home and in their communities rather than within institutional settings. The second was ensuring that DSVs have access to sufficient pay, personal protective equipment, and paid leave when they need it. The third was including people with IDD in all emergency preparedness and response efforts. So not just those that are related to COVID, but all emergency preparedness and response efforts. And then fourth was prioritizing people with IDD and their supports in vaccine distribution and administration plans. To address the other questions about, essentially, how do we do this and who should do it, we learned that infographics and video testimonials from individuals with IDD and their families, and then policy briefs, but only when they're actually brief, are seen as effective modalities for this type of, for really getting this information into the hands of policymakers. And then finally, we learned that collaboration is really important, and that's not a new finding, but particularly within this area of knowledge translation, approaches that draw equally from the expertise of researchers, the expertise of professionals, and the lived expertise of people with IDD and their families are recognized as really as the most effective approaches. So that's the summary of the 3 studies. I'll say that I'm really glad to report that some of these policy priorities that we identified are already in the process of being addressed in our state and nationally. So that's exciting, and a lot of our staff have, this is just one example of work that we've been doing over the past year. Several of our center staff had been working hard all year to coordinate these weekly informational sessions for all of the Georgia disability community to disseminate credible and accessible information about the virus and about the vaccine, and to address some of these emerging priorities. And so those sessions had been really well attended since the start of the pandemic. It had really been a coordinated and a great effort across different organizations and agencies across the state. So again, that's just another example of some of the work that we've been doing. We've got a lot going on, and we're really glad that we have resources to be able to support Georgians with disabilities in this way.
Well, that's fascinating. And before we move on, I'm just curious, do you have to, or how do you modify your study or questionnaire to when dealing with the disabled community? Is there a particular way you do that? And then what are some sample questions that you ask?
Yeah, that's a great question, Brian. So I can answer this in a couple different ways. So the survey that we used for study 1 is a survey that was actually developed for and then validated within populations of people with intellectual and developmental disabilities, which is really one of the main reasons why we selected that particular measure of quality of life over, the other hundreds of measures of quality of life that exist for use in this project. So because it was designed specifically for use in populations with IDD, we didn't need to make any modifications to the questions. Now, with that said, there are very few measures that are constructed and validated with people with IDD in mind. And so, that's definitely a barrier to think about in terms of researchers who do want to include people with IDD within their studies so that we can know more about this population. There are very few measures available to be able to do that. The second way that I can answer that question is related to our interview questions. And so one of my practices, and I think this is shared across certainly the faculty in our center, and I'm sure faculty across our School of Public Health, is to pilot test questions with the people that are members of the community that you're working with before you implement them with your actual study sample. And so this is a practice that I hope is embraced by everyone, especially researchers like myself and others who are working within populations that we're not a part of or we don't identify with. Because we want to make sure that the questions we're asking are, one, meaningful to participants. We want to make sure that they use language that participants understand and recognize. And really, most importantly, I think we want to make sure that the questions we ask are actually asking what we think they're asking. And so I can give a couple of examples of interview questions that are pretty general that we asked people with IDD in the qualitative study. So we asked really broad questions just to get a sense of kind of what is it that's going on. So one of the questions that we asked, really at the beginning of interviews was like, how are you doing now? Just how are you doing now during the pandemic and what's going on in your life? Just again, to get that real general sense of, what does this person's life look like and how might it be disrupted by COVID-19? And then other questions that were a little bit more detailed that we asked later on were things like, how has your life changed since the pandemic started? What are the things that are harder for you? Is there anything that's easier for you now that we're in this pandemic? And so I think those are examples of questions that are simple that you could really ask almost anyone and get the types of kind of rich responses that we're looking for.
Gotcha. Thank you. So moving on then with our second main question. So can you tell us why your research is so important?
I can. So I could spend a lot of time answering this question, I'm sure, but I'll talk just about one main reason why this work is important, is because research like this has the potential to contribute toward improving disability health equity. We know that about more than 25%, it's actually closer to 26% of the US population has some type of disability. And that can include intellectual and developmental disabilities, that includes sensory disabilities, mobility disabilities, mental health disabilities, and other categories. And from that, we know that approximately 8 million people in the US have intellectual or developmental disabilities. And it's pretty well known that among that population, people with IDD experience some of the most profound health disparities across almost all health indicators. With COVID-19 in particular, people with IDD have been disproportionately impacted, and they continue to be disproportionately impacted by COVID-19. They're at heightened risk for getting COVID-19 due to multiple factors. They're more likely to live in congregate or group settings, so that has an effect. They have an increased prevalence of secondary health conditions like heart disease and type 2 diabetes that we know can impact risk. People with IDD are also at increased risk for experiencing adverse outcomes if they do get COVID-19. And so again, there are multiple factors that play into that disparity, but one that comes to mind in particular is that people with IDD have reduced access to accessible and culturally competent healthcare. So in summary, this is important because it shines a light on some of these health disparities that are faced by people with IDD and the factors that influence the health disparities so that we can better understand how to address them.
Gotcha. So I guess a quick follow-up, are there any historical examples that mirror what is happening today which has shaped your research?
Yeah, so there has been a lot of work in the area of emergency preparedness and response. One example that I think it's an accessible example for people. I know it's getting to be kind of an old example, but is Hurricane Katrina. From research that had occurred around Hurricane Katrina, which is a natural disaster that happened in 2005, we know that people with disabilities are anywhere between 2 and 4 times more likely to die in emergencies and natural disasters than people without disabilities. So there is research around issues like that, and particularly in the area of natural disasters and weather events. But I think within the example of COVID-19, you know, from Katrina, we learned ways that we need to respond to needs in terms of evacuating people from their homes and making sure that they have access to the services and supports that they need when they're removed from their homes. Whereas with COVID-19, it was a little bit, you know, I'll say unprecedented, even though I know we're all sick of that word. But in COVID-19, we really needed to know how to keep people at home, to keep them safe and to get them the services and the supports that they need without being able to leave their home. So I think while there are, you know, there's data and there's research, COVID-19 is unprecedented. Again, I hate to say it, but that's what we found. We really lacked some of the important data that we needed to be able to respond well to COVID-19, as you know, at the federal level.
Interesting. So on to the final main question. How can we as a community concerned about public health become involved with your work?
Yeah. So the first thing that I think is important that all of us can do, and it's not specific to COVID-19, or I mean, it can be specific to any type of pandemic or illness, is to encourage that people in our families and communities get vaccinated. So yes, you know, this is important for COVID-19, but thinking about this fall, there will be yet another year of flu, and that will always go on. And as public health professionals, we have the skills and we have the tools to help our families and communities understand, you know, why getting vaccinated is important, not just for us. I mean, it's important for us as individuals, but it's important for our communities and our cities and for the whole country. And so, you know, we really need to be able to communicate to our loved ones that as more and more people get vaccinated, the risks of contracting COVID or other illnesses and dying from those illnesses among the people who are most vulnerable in our communities decreases. If the goal of public health, which I mean, this is the goal of public health, is to improve the whole population's health, then taking steps like a vaccination that we know reduce morbidity and reduce mortality among those who have the highest risk is really one of the best ways to get there. The second way that everyone can help, that's really more related to kind of general public health research and programming, is to be an advocate for inclusion. You know, one of the many reasons why health disparities continue to persist in the disability community is that people with disabilities have historically been excluded from public health research, programs, policies, and services. So be an advocate for increased representation of people with disabilities in all of the public health efforts that you work on, not just those that are focused on disability, but all public health efforts. So, you know, if you're listening, I encourage you, speak up, ask questions. You know, if you're working on a public health initiative through your practicum or internship, and you notice that there aren't people with disabilities at the table, or people with disabilities are not included in the design, implementation, and evaluation of any particular public health or health equity initiative, say something. You know, you don't have to be a disability expert. You don't have to know all the answers in order to be an advocate. But I think really that's one of the ways that all of us can work together to powerfully move the needle on advancing health equity for everyone.
And just putting you on the spot there, do you have anything on the CLD website that we can look at for resources, at least to contact if we have questions like that come up?
Yeah, absolutely. All of us at the CLD are always willing to be an expert in this space. You know, if people are trying to say, hey, you know, we need some technical assistance about how to include people with disabilities in this initiative in a way that's meaningful and honors their experiences, we'd be happy to connect you with community-based organizations, state agencies, and others who are doing this work to make sure that inclusion happens.
Great. Well, we're running short on time, so I only have a couple more questions. And this is one, just curious, is there any attention to the issues that you've discussed at the federal level, given all the recent funding allocated to address the pandemic?
Yes, the answer is yes. Thankfully, there has been attention at the federal level. So one thing I can share, you know, this is recently emerging, but So our center, the Center for Leadership and Disability, we receive our core funding. So we have a core grant from the Administration for Community Living, which is part of the U.S. Department of Health and Human Services. And so our center and all of the 67 centers like ours throughout the country have recently received notice that we'll have the opportunity to receive supplement funds, so funds that are supplemental to that core grant that we receive, to address some priority vaccination issues for people with IDD and their families and caregivers. And so this is part of a larger initiative. Lots of other networks are involved, and again, it's federal, but like the Centers for Independent Living in Georgia and in other states, the State Protection and Advocacy Systems, and then state councils on developmental disabilities, and then some of the aging networks have also received some of these funds to do the work. So we just had a meeting this morning. We had a meeting last week about it, and we're still working within, our state partners to figure out what the priority needs are, where the needs are, and how we can really develop a coordinated response in Georgia. But it's really good to know that, similar conversations are taking place throughout the country and that our network's infrastructure is being utilized in this way.
Great. That's good news to hear. So while my last bit of time here, my final question for you is, are there any lessons that we have learned during the pandemic which will address your research over the next 3 to 5 years? And then how would that affect policy going forward?
Yeah, absolutely. We're going to continue learning so much from the COVID-19 pandemic and from our response to the pandemic. But one factor that I've been particularly interested in is understanding just how important expanding access to telehealth and telemedicine has been for many communities, including people with IDD during this time. And so, just one sentence of background, that expansion of telehealth and telemedicine has really allowed more people to access the services and support that they need to live healthy and independent lives. So the types of services that are available through telehealth and telemedicine have been expanded. And so there are lots of advocacy groups out there that are asking, let's take these expanded telehealth options and the temporarily expanded reimbursement policies for telehealth services that we developed during the pandemic and make sure that those remain in place beyond the pandemic. And so that's really one lesson learned that, I think has the potential to change lives. And I'll say I look forward to any opportunity that we have at CLD to conduct research and conduct community programming so that we can help inform policy around that issue.
Great. Well, I want to thank everyone for attending the Currents of Public Health webinar today, and I especially want to thank Dr. Vinoski Thomas for her informative presentation. This is the final webinar of the spring series, so be on the lookout for information about the upcoming fall series. In closing, the School of Public Health at Georgia State University is one of the most diverse schools of public health in the nation, offering a Bachelor of Science in Public Health, a graduate certificate, a Master of Public Health degree in 6 concentrations, a PhD degree in 4 public health areas of knowledge, and a Doctor of Public Health degree. The faculty and students conduct research on the complex public health challenges facing cities across the globe. Our work is often carried out in partnerships with communities, their residents, and community-based organizations committed to health equity. If you'd like more information about our programs or how to support the work of the school and our students, please visit publichealth.gsu.edu. Thank you again to Dr. Vinoski Thomas, and thank you all for attending. Please join us for our next webinar this fall.